Picture this. You're in your GP clinic. A 74-year-old man walks in. He's got atrial fibrillation. He's on a DOAC, and he had a stent placed 6 weeks ago for a stable angina. The cardiologist sent him home on the DOAC plus clopidogrel. The question on his mind and yours is simple. When can I stop the clopidogrel? For years, the default was 12 months. This week, a landmark trial says you can probably stop at 1 month, and your patient will bleed a lot less.
Good morning. It's Wednesday, the 5th of August, 2026. 4 stories today, all published in the last 2 weeks. We're covering antithrombotic strategy after stenting in atrial fibrillation, antihistamines for eczema, magnesium sulfate for preterm neuroprotection, and a surprising finding on Rivaroxaban for migraine. Let's get into it.
Story 1. The OPTIMA-AF trial published in The Lancet on August 1st. This is a Japanese multi-center randomized trial, just over 1,000 patients with atrial fibrillation undergoing PCI, all done with intravascular imaging guidance. Patients were randomized to 1 month of dual antithrombotic therapy, meaning DOAC plus a P2Y12 inhibitor like clopidogrel, followed by DOAC alone, or the standard 12 months of dual therapy before stepping down. The primary efficacy endpoint was a composite of all-cause death or thromboembolic events at 12 months.
And the headline result?
1 month was non-inferior to 12 months for efficacy. Death or thromboembolic events occurred in 5.4% of the 1-month group versus 4.3% of the 12-month group. The confidence interval crossed the non-inferiority margin, so they met their endpoint. But here's the big finding. Major or clinically relevant bleeding was halved, 4.5% in the 1-month group versus 8.8% in the 12-month group. Hazard ratio 0.5, statistically significant superiority for safety.
So you're trading essentially identical protection from strokes and stent thrombosis for half the bleeding risk. That sounds like a clear win. But let me push back. This was an open-label trial. Clinicians knew which arm patients were in, and all PCIs were done with intravascular imaging guidance, which is not standard practice in most countries, including Australia. Does that limit how we generalize this?
Both fair points. The open-label design is a limitation, though events were adjudicated by a blinded committee. The intravascular imaging requirement is interesting because it means stent deployment was optimized, which could reduce stent thrombosis risk and make early cessation of antiplatelets safer. In a center that doesn't use routine IVUS or OCT, you might be more cautious, but the signal is consistent with a growing body of evidence. The Augustus trial, the INTRUST-F PCI trial, both showed that shorter durations of antiplatelet therapy in AF patients after PCI reduce bleeding without increasing ischemic events.
And the population matters here. Median age 76. CHAD's 2 score of 2. These are your typical older GP patients with AF who end up needing a stent. The median follow-up was 540 days, so we have solid medium-term data.
Exactly. The practical takeaway for the GP is this. When your AF patient comes in after a stent, and they're on a DOAC plus clopidogrel, the question of when to stop clopidogrel doesn't need to default to 12 months anymore. 1 month is evidence-based for patients with predominantly chronic coronary syndrome. For acute coronary syndrome, the evidence is less clear, and you should follow cardiology guidance. But for the stable patient, early cessation looks safer.
This connects to something we've discussed before, the broader theme of deprescribing. Less is more when the evidence supports it. Reducing dual therapy duration from 12 months to 1 month in this population is a tangible win for bleeding reduction. Let's move to story 2, which is about a medication almost every GP prescribes without thinking.
Story 2. Antihistamines for eczema. A systematic review and network meta-analysis published in the BMJ on July 29th. 47 randomized trials, over 6,200 patients, mostly children and adults with moderate to severe atopic dermatitis. The question is simple and one that every GP faces weekly. Should you add an oral antihistamine on top of topical steroids and emollients for eczema?
And I suspect the answer is not what most prescribers think.
Correct. The answer is probably no. With moderate certainty, adding a first or second generation H1 antihistamine resulted in a statistically significant but clinically unimportant reduction in eczema severity and itch. The improvement in eczema severity scores was about 1.9 points on an 83-point scale. The minimal important difference is 8.2, so the effect is less than a quarter of what patients would notice. For itch, the reduction was less than 1 point on a 10-point scale, where the minimal important difference is 3.
So the effect is real but meaningless at a patient level. That's a crucial distinction. Statistical significance without clinical significance. And what about the harms?
This is where it gets important. First-generation antihistamines, your chlorpheniramine, your promethazine, probably increase cognitive impairment, and they may increase treatment discontinuation due to adverse events. That's 66 more per 1,000 patients stopping because of side effects. For second-generation agents, the cognitive impairment risk varies. Loratadine looks cleanest. Cetirizine and levocetirizine carry a small but measurable risk. And importantly, no antihistamine improved sleep disturbance or reduced eczema exacerbations.
Let me be devil's advocate. Some clinicians argue that sedating antihistamines given at night help children sleep through the itch. Is there no role for that?
The data says the sleep benefit doesn't hold up. With low certainty, none of the studied interventions improved sleep disturbance. The sedation from first-generation agents is not the same as restorative sleep. You're sedating the child but not breaking the itch-scratch cycle. And the cognitive impairment signal, especially in children who are developing, is a real concern. This review will inform updated clinical guidelines, and the direction is clear. Routine antihistamine use in eczema is not supported.
This is a deprescribing moment. How many times have we all prescribed cetirizine alongside a topical steroid for eczema, almost reflexively? The evidence says the topical steroid and emollient are doing the work. The antihistamine is adding noise, not signal. And for the parents who demand something for the itch, this is the evidence you can show them. The benefit is below what they'd notice, and the side effect profile is not trivial, especially with first-generation agents.
Exactly. And this comes from a high-quality team. Gordon Guyot is a co-author. This is a grade-informed network meta-analysis with patient representatives involved. It's the kind of evidence that should change guidelines. The message for your clinic tomorrow is, focus on optimizing topical therapy, addressing trigger factors, and considering referral for systemic agents like dupilumab or upadacitinib in severe cases. The antihistamine is not your friend here.
Strong message. Let's pivot to story 3, which is for the obstetrics discussion. Tell your wife about this one.
Story 3. Antenatal magnesium sulfate for fetal neuroprotection before very preterm birth. Published in the American Journal of Obstetrics and Gynecology on July 30th. This is an Australian and New Zealand population-based cohort study using the ANZNN registry, the Australian and New Zealand Neonatal Network. Over 16,500 neonates born before 30 weeks gestation between 2012 and 2020.
That's a massive dataset, and this is a real-world study, not an RCT. What's the rationale for looking at this now?
The RCT evidence for magnesium sulfate neuroprotection has been around for 2 decades. The Cochrane review showed it reduces cerebral palsy, but the question has always been whether the benefit translates into routine clinical practice, where implementation is patchy, dosing varies, and the sickest, most premature infants are involved. This study looked at real-world outcomes across Australian and New Zealand neonatal units.
And what did they find?
Among about 6,700 infants with 2 to 3 year follow-up data, magnesium sulfate exposure was associated with a 17% reduction in death or cerebral palsy, adjusted relative risk 0.83, and a 12% reduction in death or moderate severe functional impairment, adjusted relative risk 0.88. For singleton pregnancies, the cerebral palsy reduction was even clearer. 32% fewer cases, adjusted relative risk 0.68.
Let me interrogate this. This is an observational study, so confounding by indication is the obvious concern. Were the sicker mothers or the ones with more time to receive magnesium systematically different from those who didn't get it?
That's the right question. The authors adjusted for gestational age, sex, birth weight, antenatal steroids, mode of delivery, and other confounders, but residual confounding is always possible in a retrospective cohort. The strength of this study is its size and its population base. This is essentially every extremely preterm baby born in Australia and New Zealand over 8 years. The signal is consistent with the RCT data and shows that the benefit does translate into routine care.
And for the obstetrics trainee, what's the practical message?
The message is that magnesium sulfate works in the real world. If you have a woman in threatened preterm labor before 30 weeks and she doesn't have a contraindication, give the magnesium. The protocol is typically a 4-gram loading dose over 20 minutes, then 1 gram per hour infusion until birth or for up to 24 hours. This study confirms that when we do this in Australian units, babies have better outcomes. Fewer die, fewer develop cerebral palsy, fewer have severe disability. The Crowther Group at SHMRI and the Liggins Institute names you trust in this space.
The implementation gap is the real issue, isn't it? We know magnesium works, but not every eligible mother receives it, especially in rural and remote settings where transfer timing is tight.
That's exactly right, and that's why this real-world evidence matters. It demonstrates the benefit persists outside the trial setting, which strengthens the case for protocols that ensure every eligible woman receives it, regardless of where she presents. This is particularly relevant for rural practice, where you might be the one making the call to start magnesium before retrieval.
Good point. This connects back to the systemic quality improvement theme. Evidence only matters if it's implemented. Let's move to story 4, which takes us into neurology and a genuinely surprising result.
Story 4. Antithrombotic treatment for migraine in patients with patent foramen ovale. Published in the BMJ on July 29th. This is a Chinese multi-center randomized trial, 1,000 adults aged 18 to 64 with migraine for at least a year, at least 4 migraine days per month, and PFO confirmed on echocardiography, no previous stroke or TIA. They were randomized to aspirin, clopidogrel, Rivaroxaban, or metoprolol for 12 weeks.
Metoprolol as the active comparator is interesting. That's a standard migraine preventive, and the antithrombotic arm is testing the hypothesis that microthrombi or platelet activation through the PFO contributes to migraine. What was the primary endpoint?
The proportion achieving at least a 50% reduction in monthly migraine days or attacks from baseline to weeks 9 to 12. The results were striking. Responder rates were 62% for aspirin, 67% for clopidogrel, 78% for Rivaroxaban, and 62% for metoprolol. Rivaroxaban was superior to metoprolol with an absolute difference of 16%. No major bleeding events were reported.
78% responder rate with Rivaroxaban is remarkable. That's higher than most migraine preventives achieve. But I have to be skeptical. 12 weeks is short. This was open label. And the mechanism, why would an anticoagulant help migraine in PFO patients?
The proposed mechanism is that right-to-left shunting through the PFO allows microthrombi or vasoactive substances to bypass the pulmonary circulation and reach the cerebral vasculature directly, triggering cortical spreading depression and migraine. Anticoagulation would reduce microthrombus formation. It's a plausible biological hypothesis, though unproven. The trial was open label with blinded outcome assessment, which is a reasonable design, but not double-blind.
Let me raise the elephant in the room. PFO closure for migraine has been studied extensively and the results have been mixed at best. The MIST trial trial, the PRIMA trial, the PREMIUM trial, all showed no significant benefit of PFO closure for migraine. If the structural defect isn't the problem, why would an anticoagulant work?
That's the key tension. This trial doesn't answer the mechanism question. It's possible that Rivaroxaban is acting through an anti-inflammatory or neural effect independent of its anticoagulant properties, or it's possible that the open-label design introduced expectation bias even with blinded assessment. The no major bleeding result is reassuring, but 12 weeks is a short exposure for a bleeding signal. Before we start prescribing DOACs for migraine, we need a double-blind RCT with longer follow-up.
Agreed. This is hypothesis generating, not practice changing. But it's a signal worth watching, especially for the subset of migraine patients who have a PFO and haven't responded to standard preventives. For the GP, the takeaway is that PFO-Migraine is an active area of research. And if a patient with refractory migraine is found to have a PFO, referral to a headache specialist or neurology with interest in this area is reasonable. Don't start Rivaroxaban off-label for migraine.
Well said. Let's do our quick hits and recap.
Quick hits. First, a Lancet study from Latin America, the LatAm-FINGERS trial, showed that a structured multi-domain lifestyle intervention, diet, exercise, cognitive training, over 2 years, improved cognitive scores in at-risk older adults across 11 countries. The effect was modest but adds to the FINGER trial evidence that lifestyle matters for brain health. Reinforce the basics with your older patients.
Second, the TGA safety alert page has not had new alerts since early July. All recent alerts, ashwagandha, counterfeit honey sachets, underdosed SARMs, remain the current ones. If you're seeing unexplained liver function abnormalities, remember to ask about ashwagandha supplements.
Third, PBS changes for August are already in effect. The big ones we covered last episode, abaloparatide for osteoporosis, tildrakizumab for psoriasis, expanded pediatric Crohn's disease biologics. No new changes expected until September 1st, when clopidogrel and GTN patch brand deletions are expected.
Let's recap. Story 1. OPTIMA-AF. 1 month of dual antithrombotic therapy after PCI and atrial fibrillation is non-inferior to 12 months and halves bleeding. Shorten the duration for your stable patients. Story 2. Antihistamines for eczema. Clinically unimportant benefit, real harms. Stop prescribing them routinely. Story 3. Magnesium sulfate for preterm neuroprotection. Real-world Australian data confirms fewer deaths and less cerebral palsy. Give it to every eligible mother. Story 4. Rivaroxaban for PFO-Migraine. Promising signal but not ready for prime time. Watch this space.
See you tomorrow. Stay sharp.